Hey everyone, I'm Monica and I'm an internal medicine attending, and my goal is to help you succeed in medicine whether you're a medical student or a resident. So today we're going to be covering the causes of hyperkalemia. And I am going to go into a lot of detail because I really want you to understand what's going on and understand the physiology behind things. But if you are just here for a quick review, feel free to jump around using the timestamps or skip ahead to the 30-second review at the end. So here's our agenda for today. We're going to do a very quick review of potassium regulation. Then we're going to go into each of the causes of hyperkalemia. And just as a spoiler, that is going to include increased potassium intake, intracellular to extracellular shift, reduced potassium excretion, and pseudohyperkalemia. And then at the end, since we're going into a lot of detail with each bullet point, we're going to do a quick 30-second review to wrap everything up. To actually understand the causes of hyperkalemia, I recommend watching this video to understand it in full detail. But just real quick, we're going to go through some of the major points. So when you take in potassium, the concentration of potassium in your serum is going to go up. So your body is going to put a lot of processes into place to bring that potassium level down. So first you have the sodium-potassium ATPase that sits in all cell membranes, and it pumps potassium into the cell while it sends sodium out. And then the adrenal glands are going to secrete aldosterone. And aldosterone is the primary hormone that controls potassium levels. So aldosterone is going to go to the kidneys and increase potassium secretion so that it's excreted in the urine. So the primary way your body gets rid of potassium is going to be through the urine. So now that we've laid that foundation, let's actually dive into the causes of hyperkalemia. So let's get the definition of hyperkalemia out of the way. So the definition of hyperkalemia is a potassium concentration of greater than or equal to 5.5 milliequivalents per liter. So before I really go into the explanation for each of these bullet points for the causes of hyperkalemia, I do want to give you a little bit of a teaser for each so you know what to expect. So the first one is increased potassium intake. So you would think that if you took in a ton of potassium that you would raise your serum concentration by a lot. But that's actually not the case because the kidneys are so awesome and it's really hard to beat them. So if they're working normally, they're going to work really hard to get rid of any extra potassium and keep your potassium level within that tight normal range of 3.5 to 5.5 milliequivalents per liter. But again, this is assuming that they're working normally. So if they're not, so if you have a patient with chronic kidney disease, for example, the kidneys are not going to be able to get rid of that extra potassium, and that's when it's actually going to cause a problem. So remember that potassium is primarily an intracellular ion. So if you get a huge shift of potassium from inside the cells into the blood, then you're going to get hyperkalemia, because hyperkalemia is the concentration of potassium in the blood, not in the cells. So we'll go over the various causes of intra to extracellular shift. Next is reduced urinary excretion. So this can happen in two ways. One, like we already talked about, if your kidneys aren't working properly, you can't get rid of the potassium at an adequate rate. But two, this also happens if you have low aldosterone levels. So remember earlier when I said that aldosterone is the primary hormone that controls potassium concentration. If you have high aldosterone, you're going to increase potassium secretion in the kidneys and you're going to lower the potassium concentration in the blood. So if you have low aldosterone levels, then you're going to be at risk for hyperkalemia. And then there's actually something called pseudohyperkalemia, and it's exactly what it sounds like, fake hyperkalemia. So don't be fooled by this. Even the blood drawing technique can artificially raise the amount of potassium in the blood sample. And if you get cell breakdown in the blood sample, that will also make it look like the patient has hyperkalemia when they actually don't. So there's not really much else to say about number one and number four. Number one, I pretty much already said it. If you have increased potassium intake and you don't have normal kidney function, you get hyperkalemia. And then number four is pseudohyperkalemia, which isn't even real. So instead, I'm going to focus on the other two categories, transcellular shift and reduced urinary excretion. All right, so first, transcellular shift. Transcellular shift means you're moving potassium from inside the cells to outside the cells. So if you have too much potassium moving from inside the cells to outside the cells, you're going to cause hyperkalemia. So let's break this down further. What causes transcellular shift? So the first one we're going to be talking about is metabolic acidosis. So when you have metabolic acidosis, you have all these hydrogen ions floating around. So the cells are going to want to take up these hydrogen ions to bring the pH back to normal. But the cells are also obsessed with maintaining electroneutrality. So when they take up a hydrogen ion, they're like, wait, I have to actually now give up something to maintain electroneutrality. And that ends up being a potassium ion. So the cells are taking up hydrogen ions and releasing potassium ions instead. But the problem with that is that if it happens too much, then you're actually going to cause hyperkalemia. Now I put an asterisk next to metabolic acidosis because remember that this only happens in non-anion gap metabolic acidosis. It does not happen in anion gap metabolic acidosis. So why not? The reasons are actually not that well understood, but it's thought that these organic anions can actually follow their hydrogen ions into the cell, so the cell doesn't actually have to give up another cation in exchange for that hydrogen ion to maintain electroneutrality. What about respiratory acidosis? Respiratory acidosis also tends to lower the blood's pH, and it does cause hyperkalemia, but not to the same extent as metabolic acidosis. It's actually not well understood why this is, and that's all I'll say about that. If you watched my video on potassium regulation, then you know that insulin stimulates the sodium-potassium ATPase pump to shift potassium into the cells. So it makes sense that insulin deficiency is going to do the opposite. It promotes potassium shift out of the cells. In what medical condition do you have a deficiency of insulin? Yes, diabetes. So poorly controlled diabetes promotes hyperkalemia. And there's actually a lot of factors that cause hyperkalemia in diabetes. It's not just the insulin deficiency. Remember that if you have diabetes, your cells cannot take up glucose efficiently. So you have a ton of glucose floating around in the blood, and that raises the serum osmolality. And that hyperosmolality is going to create an osmotic gradient that drags water out of cells. And when that water is dragged out of cells, it brings some potassium with it. This is called solvent drag. Also, if you move water out of the cell, you're going to increase the intracellular concentration of potassium. And so that is going to create a concentration gradient that's going to promote passive movement of potassium out of the cell through potassium channels in the cell membrane. So diabetes is actually not the only example of hyperosmolality causing hyperkalemia, but it's by far the most common situation that you'll see. So in summary, in poorly controlled diabetes, you have three factors that are going to cause hyperkalemia. One, the deficiency of insulin itself. Two, the solvent drag that's caused by the hyperosmolality, which is caused by the hyperglycemia. And three, a concentration gradient favorable for passive potassium movement from inside the cells to outside the cells. So increased beta-adrenergic stimulation shifts potassium into cells. So beta blockers are going to inhibit that. So they're going to keep potassium outside the cells and cause hyperkalemia. So beta blockers are not the only medications that shift potassium out of cells. There's actually a lot of different medications, but I'll just highlight two that you'll see commonly on your clinical rotations or that you'll be commonly tested on. So the first one is digoxin. So digoxin inhibits the sodium-potassium ATPase pump so that, again, the potassium stays out of the cells, and that can lead to hyperkalemia. This one is actually pretty commonly tested. So remember, digoxin can be a cause of hyperkalemia. The second medication I'll mention is succinylcholine. So succinylcholine is used in general anesthesia, and the way it works is it's actually a paralytic. So it causes widespread muscle depolarization. And when that happens, there's a lot of potassium that's released from the muscle cells, and that is what leads to hyperkalemia. So the next one is hyperkalemic periodic paralysis. So hyperkalemic periodic paralysis is actually a super interesting disease, and it's a genetic disease that's autosomal dominant. So these patients will get a diffuse paralysis after certain triggers, like the cold, or rest after exercise, and ingestion of small amounts of potassium. So again, after these triggers, these patients will get this diffuse muscle paralysis, and that leads to an efflux of potassium out of the cells, and so that's how they get hyperkalemia. So this is a pretty rare disease, but I would actually keep it in your back pocket for like medical trivia, or if you're part of a discussion for a case, you can throw it out as part of the differential diagnosis and impress everyone. So the last one I'll talk about is cell lysis. So potassium, once again, is primarily an intracellular ion. So if you have massive tissue breakdown where all these cells are dying, they're all releasing all this potassium into the blood. So in any case where you have widespread massive tissue breakdown, then you're gonna get hyperkalemia. And you can get pretty serious hyperkalemia from this. And so in my head, when I think about it, I think of this round cell with all this potassium that just like bursts and releases potassium into the blood. And this is literally what's happening in some conditions like trauma, serious trauma like crush injuries, rhabdomyolysis where you have widespread muscle breakdown, and 3, tumor lysis syndrome. Tumor lysis syndrome is definitely one that you're going to be tested on a lot, along with rhabdomyolysis. So there we have our list of causes of intra to extracellular shift of potassium. So let's move on to our next big category, and that is causes that are related to reduced urinary excretion. 1, low aldosterone levels or hypoaldosteronism, resistance to aldosterone, acute and chronic kidney disease, so your kidneys just aren't working well, and 4, reduced sodium and water delivery to the distal nephron. So let's break each one of these down in detail. So the first one I'll talk about is low aldosterone levels. So remember that aldosterone increases potassium secretion, so if you have low aldosterone levels, then you're going to decrease potassium secretion, leaving more potassium in the blood, causing hyperkalemia. If you really want to understand how aldosterone does this, again, I highly recommend going back and watching my video on potassium regulation after you finish this video. So how do we get low aldosterone levels? Well, there are 3 causes for this. 1 is low renin levels, so you have hyporeninemic hypoaldosteronism, 2, medications, and 3, primary adrenal insufficiency. So remember the renin-angiotensin-aldosterone system. You have renin produced by the kidneys, and then a couple steps later, you eventually get aldosterone released from the adrenal glands. So if you have low renin levels, you're gonna have low aldosterone levels. So what causes hyporeninemic hypoaldosteronism? There's a couple causes. 1 is advanced kidney failure. So you literally do not have enough functioning nephrons to even produce enough renin to produce enough aldosterone. And 2, the most common one you'll see is diabetic nephropathy. So several medications cause hypoaldosteronism. So first, ACE inhibitors, because they suppress the whole renin-angiotensin-aldosterone system, so you have low aldosterone levels. Another group of medications is NSAIDs, and then another one is calcineurin inhibitors. So these are medications that you'll see used often in solid organ transplant patients, and the 2 most common ones that you'll see are tacrolimus and cyclosporine. And then the last medication that's commonly used is heparin. And then finally, primary adrenal insufficiency causes hypoaldosteronism, because in primary adrenal insufficiency, all layers of the adrenal gland are affected, so you don't actually produce enough aldosterone. So you can also have a resistance to aldosterone or a reduced response to aldosterone. So that means that even if you have normal aldosterone levels, your kidneys aren't reacting to what aldosterone is trying to do. And causes of this situation of reduced response to aldosterone actually include medications that are specifically designed to do this. And those are the potassium-sparing diuretics. And there's 2 types of potassium-sparing diuretics. The kind that actually directly antagonize aldosterone, and that includes spironolactone and eplerenone. And the second kind is the type that blocks the ENaC channel, which plays a large role in potassium secretion. And those are going to include amiloride and triamterene. There are other causes of reduced response to aldosterone, and that includes a type of renal tubular acidosis, or RTA. But RTAs are a whole different can of worms, and they deserve their own video, so I'm not going to go into detail on those today. So next we have acute and chronic kidney disease. So this one's a little more obvious, right? Because again, the kidneys, which are the main organ that gets rid of potassium, if your kidneys aren't working, then you're not going to be secreting enough potassium, therefore causing hyperkalemia. Now, the kidneys are so awesome that if you have acute kidney injury, you usually have to have another process on top of that that promotes hyperkalemia. So like you have acute kidney injury plus rhabdomyolysis, or you have acute kidney injury plus tumor lysis syndrome. And it's pretty similar actually in chronic kidney disease because you have to have pretty advanced kidney disease. We're talking like end-stage renal disease before you develop hyperkalemia. So these are patients that are dependent on hemodialysis. So again, even in CKD, there's usually another process that's also promoting hyperkalemia. The next one is reduced sodium and water delivery to the distal nephron. So remember that sodium plays a huge role in potassium secretion. So if you don't have a lot of sodium and water delivery to the distal nephron, you're not going to get a lot of potassium secretion. And the most common cause of this situation is low effective arterial blood volume. Let me explain. So the kidneys judge how much fluid they think the body has by how much blood flow they're getting. So in situations where that blood flow is reduced, the kidneys think, oh no, we're getting less blood, so that means the whole body must have too little fluid. So we gotta save the day and retain more fluid. And so how do the kidneys do this? They reabsorb more sodium, and that brings water with it, thereby causing fluid retention. And that sodium is reabsorbed actually in more proximal areas of the nephron. So by the time the tubular fluid comes to the distal nephron, there's less sodium in water. Less sodium in the tubular fluid means less sodium going through the ENaC channels and less potassium being secreted back out to the renal tubules to be excreted in the urine. Examples of situations where you have low effective arterial blood volume are going to include total body hypovolemia, so you actually have too little fluid in the body, heart failure, cirrhosis, and nephrotic syndrome. But I won't go into those mechanisms here. Now it's time to wrap this up in a really quick review. So, causes of hyperkalemia. You have increased potassium intake in the setting of reduced kidney function, transcellular shift, so potassium going from inside the cell to outside the cell, and reduced urinary excretion of potassium. Causes of transcellular shift include metabolic acidosis, respiratory acidosis, but to a smaller extent, beta blockers, insulin deficiency leading to hyperglycemia and hyperosmolality, medications such as digoxin, hyperkalemic periodic paralysis, and cell lysis, which technically could be its own category, but it's the same concept of potassium going from inside the cell to outside the cell. And finally, causes of reduced urinary excretion include low aldosterone levels, resistance to aldosterone, and reduced sodium and water delivery. And that's all we have today. So thank you all so much for watching. As always, I welcome feedback in the comments, and I also welcome video ideas in the comments. And if you found this content helpful, hit the like button and subscribe for more videos on not only medical topics like this, but also on clinical skills in the wards and how to find success in the medical field in general. See you next time.